Center Hour. I'm Margaret Moorman from the Center of Biomedical Ethics and Humanities, and today's program is presented not only by the Center, but also by the School of Medicine's Generalist Scholars Program in honor of National Primary Care Week, and by the Department of Public Health Sciences. We are honored to have with us today Dr. Cynthia Romero, who is the Virginia State Commissioner of Health, and is also an alumna of this university. And we could debate which one of those honors is greater. You have a complete biography on your handout. I'm not going to go through it, not only because you can read as well as I can, but because I'm eager to get to Dr. Romero's talk. For me, as a one-time primary care pediatrician and founding faculty member of the Generalist Scholars Program at its inception some almost 20 years ago, Dr. Romero's work and what she plans to talk with us about today are close to my heart. So I'm eager to hear her, and I'm not going to delay in yielding the podium to her, and that way too we'll have plenty of time for your questions at the end. So Dr. Romero.
Thank you. Thank you, Dr. Moorman, and thank you so much, everyone, for being here. It truly is a great privilege for me to accept the invitation from the Generalist Scholars Program. Thank you so much, particularly Nellie, for contacting me and getting me involved, and certainly the Department of Public Health Sciences. It truly is a great privilege to be here to help celebrate Public Health Week, but also to be part of this Medical Center Hour. I hope in the very brief time that I have with you that I hope I can give you a perspective that will not only motivate you, but hopefully invigorate you and the person next to you if you have someone next to you. And hopefully see that each of us have a great opportunity to be a part of creating healthier communities. And each of us probably came to this great institution of learning because of our curiosity and our desire to learn. But it's actually going to be the leadership that each of you guys take, hopefully from here, that will lead into more successful collaboration and hopefully a renewed desire for mission and purpose to work together and hopefully work on behalf of the Commonwealth. So very briefly, I plan to give you a quick reminder about what the breadth and scope of public health is. Also want to introduce you to a report that's available on our Virginia Department of Health website, our 2012 Health Equity Report, and then outline some opportunities how each of you, regardless of your profession, regardless of your status in learning and your journey in your professional life, will hopefully be able to see how you might be able to play a role in creating healthier communities by addressing families with low income, those racial and ethnic background differences, and educational differences, as well as veteran families that we're seeing are part of a disparate population. But all the more so, I hope to, again, inspire you to see that it's the collaboration between all sectors, not just health, but in fact all sectors, that really invite you to realize that the public health system really touches every aspect of a community, and in fact touches every sector within the community. So hold on to your seatbelts, and we'll breeze through this. The art and science of public health simply defines public health as the approaches to prevent diseases, to prolong life, and to promote health and wellness. The World Health Organization puts it simply that any measure or effort that really identifies health problems, develops policies and procedures to address those health problems, and then assures access to health care to address those health problems, that's public health. But the Center for Disease Control and Prevention actually has a more detailed plan and definition of what public health is. But it follows the same tenets as those of the World Health Organization definition. But you'll see there, those areas that I emphasize, they actually focus on empowering people, the public in particular, about health and health issues. They really capitalize and focus on the desire to highlight community partnerships and community efforts. And they emphasize the importance and the need to have research, to continue to have innovative and creative ways to address health problems, especially knowing how health continues to evolve and change as time goes by, but certainly how technology, medications, therapies continue to evolve and change. So research is really at the forefront of the Center for Disease Control's definition. The Virginia Department of Health really embraces the definition or definitions that the World Health Organization and the CDC promotes. We have the great opportunity to have the mission of protecting and promoting the health of all Virginians. And in doing so, we do what you probably know is the public health's role, and that's number one, preventing the spread of illnesses. You know, the public health system was really built on addressing the needs of tuberculosis infected patients centuries ago. But as time has evolved, that has really expanded as Mother Nature would have it to multiple infectious diseases. But public health really has the opportunity to continue to monitor and manage populations based on preventing the spread of illnesses and epidemics. We're also involved in protecting against environmental hazards. So who of you in the audience knew that we have 2 nuclear power plants in Virginia? So in communities that are in those areas, we need to be monitoring those for safe areas for people who live around those areas. But we have something called the shores, the eastern shores and beaches, where we're looking at environmental safety areas and assuring that there are safe places for drinking water, safe soil, looking at the amount of sewage and how that might be seeping into the soil in communities. And it's our role to actually help regulate the areas to assure that communities that could have those risk factors really are mitigating those risk factors. Preventing injuries. You know, certainly anywhere in Virginia that you're involved in activities or environments, you know, we're trying to promote safety and assuring that people who are enjoying sports on water are actually aware of how to prevent injuries while participating in those sports. Encouraging behavioral and mental health wellness. You know, certainly mental health is a big part of everyone's everyday life, but oftentimes we may not spend enough time and we may not have the resources for people to be able to get help when there are issues concerning mental health. So we in the public health sector are really geared towards trying to assure workforce and the resources are available to help address those. Emergency preparedness is a huge part of public health. In every season of hurricanes or inclement weather, disasters, potential bioterrorism attack, especially here in Virginia, the Department of Health is right there helping lead the effort to prepare our citizens for any type of disaster or hazardous event, to be able to recover during the post-event time period, and how to establish a new norm after a particular disaster has taken place. So that's really part of public health as well. And ensuring the quality and accessibility to quality health care. So again, every institution, every hospital, every training program, every physician and physician group that takes care of patients really are part of public health because they are taking care of the health of the public. So again, public health really extends and is a really broad-reaching activity. Very exciting. When we're looking at particularly public health, one of the true emphasis that we're trying to promote is our focus on population health and how are we really monitoring and managing health. It represents a very easy to understand and very simple pictorial framework for us to really appreciate what are the factors that influence, impact, and could be effective in really managing a population's health. So if you look at the very top of the pyramid with the counseling and education, this is usually the first step of any intervention, talking things through, trying to educate, provide opportunities to have individuals talk about what their particular issues are. How do you choose healthier diets? How do you become more physically active? But as you'll see, when it comes to really impacting the health of a population, its impact is relatively small compared to other things we're going to mention. Moving down the line, clinicians in the room, live and breathe clinical interventions. So how do you control populations, let's say, who are at risk for heart disease? Well, you identify individuals who have high blood pressure or high cholesterol, and you try very hard to treat them appropriately and make sure they get down to their goal blood pressure or goal cholesterol levels. And patients at risk for diabetes, identify them early, treat them, and hopefully prevent an organ disease damage. Those type of clinical interventions can be helpful to address those particular populations. But again, when you're looking at the bigger scheme of a whole population, we could be doing a little bit better. The next level down long-lasting preventive measures. Immunizations are a great example of evidence-based practices of really helping prevent certain diseases that can be prevented by immunizations. So what pediatrics try to promote in their routine visits are really, how do you prevent diphtheria? How do you prevent tetanus? How do you prevent all the conditions that we know immunization could be really helpful for? The H1N1 epidemic that occurred a couple of years ago really was able to be controlled somewhat in subsequent years because we were able to help promote and get as many of our populations immunized with the flu vaccine. Other evidence-based practices that can really help a population be healthier, screening mammographies, colonoscopies. Those tests are evidence-based. If they're done at the appropriate age-specific times, we can help identify abnormalities and get those patients treated. So that definitely helps populations. Bigger impact, though, is actually changing the context of a population. So changing a situation or circumstance so that a default behavior is in fact the desired behavior. So putting fluoride in water so that someone doesn't have to take an extra spoonful of fluoride, or children don't have to have a dropper full of fluoride. Rather, change the context. Have it so everyone who drinks water gets that extra fluoride and hence promotes better dental care. Having the legislation passed a couple of years ago of smoke-free environments, smoke-free restaurants. Talk about changing the context and talk about helping prevent smoke-related illnesses. When you can't smoke in a certain area, that's a great intervention. So that definitely can help impact population's health. But clearly the foundation of managing, monitoring, and affecting change for populations is really looking at the social determinants of health or the socioeconomic factors. So poverty, education, equity. Those are the tenets that we're going to be leading into with our subsequent conversation. The Virginia Health Equity Report that I'll share with you actually presented this depiction as a conversation piece based on the information that came from the equity report, but builds upon the framework that we just looked at from the Center for Disease Control. And basically, when we're looking at population management and population health, there are certain things that we know we can change and certain things that we know we can't. But if there are certain things that we know we can change, but because of policies, because of just dynamics within a community, we should be changing the conversation to a higher level of discussion. So when we walk through this particular depiction, you start at the very core of an individual, and that's factors that we know we can't change. The age, the sex of an individual, hereditary factors for certain chronic diseases. Those are things that we cannot change. But if you look at next ring out, they are lifestyle changes that we can help educate patients on, help educate certain populations on about decreasing smoking, increasing physical activity, choosing healthier behaviors. Those are modifiable to some extent. But when we look at what we mentioned before about the foundation of changing the true socioeconomic factors and really addressing those are those social determinants of health, those yellow rings, or the yellow ring of really looking at, are we in an area where education is really available to certain individuals and students? Is there safe transportation? Is there affordable housing? Is there access to health care? But our equity report actually reflects an even broader concept, and that is the concept of health equity. Healthcare is really geared towards the best outcomes and the best health care. But we in public health from this report will turn that around and actually say, yeah, we'd like to see health care continue to have great outcomes, but let's think of the bigger context and ask the questions of, in a particular population or a particular community, does everyone in that community have the equal chance, equal access to achieve the highest level of health? And that's what begs the big question of, if we don't, then how do we get there? And what I'll be able to elucidate for you is that that is where we have opportunity and where we see the difference between gaps in opportunities, gaps in care, and where we're falling short from achieving the highest health within a community. That's where the conversation should be. That's where policy changes should be considered, and that's where effort should be targeted because we can see those and measure those. The Virginia Health Equity Report is on the website. It's about 125 pages. If you ever want to print it out, But it's there on the website, so you can refer to it at any time. And it's really geared towards the lay people. It's really geared towards policy officials, elected leaders. And if there are any elected leaders in the audience, you'll appreciate that we would like to keep things on one page, and we'd like to have information very fact-driven, data-driven, straightforward, easy to understand, and easy to communicate. But this report was really intended for anyone to be able to look at the data, interpret it, and take it to wherever they want to take it to help make a difference. So if you're a member of the PTA and you see something that you think you might be able to have a great conversation piece with at your next meeting, it's there for your consumption. If you're an elected leader and you'd like to talk to your constituents about opportunities to improve, there for your consumption. And for all of you, just to try to see what data is telling us from Virginia, it's there, and I certainly invite you to take advantage of that information. They're great pieces of information about definitions, background information, for the gurus of data and analysis, you know, the background of methodologies and how all the elements of data were processed to come up with the data points. It's all there for you to consume, so please take advantage of it. Very high level, when we're looking at just the demographics of Virginia, looking at the past from 2000 to 2009, we've seen that the population has really evolved, it has changed, in that the highest percentage of change has been in the Hispanic and Latino population, where from 2000, 92% increase in the number of Hispanics and Latinos that are living in Virginia. The next highest percentage increase is with the American Indians at about 45%, again since 2000. The next highest number is the Asian population at 40%. And then the African American population, which is still the largest minority population in Virginia, increased by about 11%, and the Caucasian population increased by 10%. So that really actually mirrors the same changes in ethnicities that are occurring nationally. But what does that mean from healthcare standpoint, and what does that mean from a public health standpoint? If that 92% increase in the Hispanic population are coming to Virginia, it certainly behooves us to think, are those people going to be able to understand our menus, our recommendations from the office, our instructions on the medication bottles? So that's why we've seen a trend for instructions and information to be presented in Spanish. So that's definitely a trend. But it also begs us to think, what else do we need to consider in that population? Are they getting the services that they need? And are they in fact melding into the communities to be part of the workforce? Are they being a part of the economy? And so this really introduces that whole discussion. Educational attainment. This is again information from 2009. And what you might see, I'm not sure if you can see all the details there from the back, but one of the most striking features first is that middle purple graph in the middle. And what that purple graph is standing for, or that purple bar in the Asian population, you'll see is achieving bachelor's degree or higher. So bachelor's degree or higher, and you see that the Asian population was really the one achieving the highest grade there, and then the white, not Hispanic, and then the total population follows shortly behind that. But let me draw your attention to the blue bars in each of those ethnicity areas. The blue bar stands for attaining less than a high school degree. And you'll see there that the Hispanics have the highest rate in their population of not attaining a high school diploma or higher. The next population is American Indians and then the African Americans. So when we start to realize that 13% of Virginians that are aged 25 and older have not achieved or attained a high school diploma, that puts a little unique spin on what we're hopefully going to be addressing. But what's even more interesting is the national data that tells us that a higher educational attainment is correlated with a decreasing rate of mortality. So certainly from a population standpoint, if we want to have people live longer, we would want to encourage them and support them to be able to attain higher education levels. This is a slide depicting the population in poverty. About 11% of Virginians in 2009 live at poverty or below. And when we broke that 11% down into the individual populations, we'll see here that African Americans, in particular children, have the highest number in poverty. The next population are the American Indians, and then the Hispanics and Latinos. And again, many of us know the research tells us that those who live in poverty tend to have poorer outcomes, and the data reflect that they tend to have less resources and definitely less access to resources. So when we're talking about how do we help an environment, a population, a community really have opportunities to achieve the highest health, we definitely have opportunities here. Pictures really can speak 1,000 words. Yes?
Yeah, I just had a question about your last slide. Where does those numbers come from? Because I was just wondering if undocumented individuals might account for the low number of, or the relatively low number of Hispanics.
Yes, these numbers come from what we call census tracts, and every locality is defined geographically by counties, towns, cities, and those are for census purposes. And we try very hard to capture that information. Certainly from the health department, we tend to get a lot of the undocumented. So we have Vietnamese, we have Koreans, we have Hispanics. So we try to apportion them. And again, we try very hard to collect that data, but this is the best data that we have from the census tracts. Good question. So pictures really relay message better than words. And when we're looking at a reflection of poverty levels distributed throughout the Commonwealth, we'll see the very southwest tip where it's red. That's 20% of that population live in poverty. Then those that are in orange are 10 to 19%. And then the lighter green is a 5 to just under 10%. And then the darker green are really the less than 5%. So just geographically, this is telling us that place does matter. Where you live does matter in terms of living in poverty. But again, in terms of population health and population management and looking at public health policy, does geography have to be the factor that determines whether you have good health or not? We really should be saying if you choose to live in Southwest Virginia where it's beautiful and lots of opportunity for sports, you should have equal access and opportunity to be healthy and have access to health care. So therein lies some opportunity. When we look specifically at HIV/AIDS, we are experiencing a larger number and seeing a trend that we are managing patients with HIV/AIDS a lot more than a decade ago because our efforts to really screen, detect individuals who have HIV/AIDS, and we actually have the grants from the federal level to be able to help us pay for insurance for HIV/AIDS patients, pay for their medications, and definitely help support them as much as possible. But in terms of disparities and inequities, look at the highest incidence in African American males, 56.4%, which is 7 times more than their Caucasian counterparts. Talk about disparities. Then you look at the next highest prevalence, and that's in the Hispanic male population. And then you see the African American females. So again, just from pure data, having the data talk to us and to try to help drive us to better, effective opportunities and policies that can make a difference, this is a great opportunity for us to improve our health equity. Low birth weights. We know, especially in pediatrics, that having children that were born with low birth weights oftentimes struggle throughout their early childhood development, educational cognitive development, and then oftentimes related to their attainment for higher education as an adult. So we certainly want to minimize and decrease infant birth weights, or we want to increase it so that more babies really have healthier birth weights, really stay in the gestational age that keeps them healthy as much as possible. But when we look at this particular graph, it's very obvious that there's a disproportionate higher incidence of low birth weight babies in the non-Hispanic Black population. And then you see also within the non-Hispanic white population and in the Hispanic population, those are the two lower lines right there. We'd love to see all of them go down to zero. But when you see that huge disparity, again, talk about opportunity for us to improve policies. When we in healthcare are looking at how can we make changes and how do we actually look at the bigger picture, we're able to partner with Virginia Tech's Department of Agriculture and Applied Economics, where they were able to work with us and help quantify the economic burden and the cost of these disparities and of these inequities. And what they were able to do was actually categorize direct medical costs, indirect medical costs, and actually come up with summaries. So again, this is an annual average of cost based on just race alone, would have been $917 million. You know, just rural, urban versus suburban, $692 million. Income for less than 10,000, you know, those individuals who had income levels and ended up having these disparities, just from income alone, $2.36 billion, and just educational differences and gaps, almost $5 million or 4.7 million. Talk about having an opportunity just to eliminate our educational disparities, what type of changes that could do to our economy here in Virginia. Our Health Opportunity Index actually reflected a combination of the social determinants of health and actually looked at particular areas and factors and variables within a community to say what contributes to the opportunity for us to address health equity. And as I quickly just walk through these: educational attainment, how many kids are actually enrolled and stay in school; population density, what's the concentration of people; race diversity, how many different races are in a community; material deprivation, who owns a car, who rents a house; population churning, you know, the influx and the migration out of the population; job participation, how many of the population aged 16 to 64 actually are in a job; household income diversity, is there a range of income categories; affordability of housing and transportation, you know, are there affordable housing and transportation needs within a community; you know, is the community safe in terms of, you know, environmental standards and local commuting patterns; are there, you know, safe routes to school; are there mass transit opportunities; and all those contribute to whether an area had a high income level or high health opportunity index or not. And just very briefly, clearly when we looked at the racial and ethnic gap, African Americans were 5 times more likely than the Caucasian counterparts to live in areas of low health economic or health opportunity index areas. So African Americans 5 times more likely to be in the low health opportunity index areas. Hispanics 3 times likely to live in low health opportunity index areas. Again, opportunity for us to address that. Another depiction, and just focus on the lower graph there, where there is clearly a strong correlation between health opportunity index and life expectancy. So in areas where we've seen high health opportunity index, the life expectancy is definitely higher. And there are areas where there are low health opportunity indexes and life expectancies are lower. So the opportunity for health opportunity index is simply to get a snapshot of how we're doing across locales in Virginia and see the opportunity where social determinants of health really can impact the quality of health within those locales. And it gives us an opportunity to really look at how are, you know, different collaborations occurring within those localities, and really beg the opportunity to say that collaboration is necessary across all sectors, and that where you actually live, the geographics really can make a difference. Very briefly, veterans. Virginia has one of the highest populations of veterans just by nature of all the military institutions that we have. But unfortunately, we're seeing that they have some of the lowest health outcomes because of uncoordinated care. They're not getting their issues identified. They're not relaying some of their mental issues that they may be struggling with. And recognizing that we have young veterans that are less than 15 or less than 30 years old that have gone through several tours in the military and, you know, really are trying to acclimate back. We have great opportunity by simply asking, are you a veteran? Have you served in the military? And in fact, that should open up our conversation to hopefully connect them with issues. So opportunities for you as a group is to simply continue to take care of your patients as best you can, recognizing that a primary care base, you know, certainly family physicians are geared towards thinking of patients and populations because of the way family physicians are trained. Primary care in general really look at individuals in the context of the biopsychosocial model. But it should behoove all specialties and in fact all sectors to really consider how do you prevent particular diseases, how do we keep people well, and how do we connect them to specialty care once they get diagnosed. Keep those unspoken things that we talked about, education, ethnicity differences, in the back of your mind when you're trying to take care of the patients. Lead by data. Let the information guide you to take care of the individual patient, but certainly take care of the entire population. And partner with each other. This is a great opportunity for us to really talk to each other, to collaborate and see where we have opportunity, and to continue to have leadership moving forward. I'll end with these last three quotes that are my favorite. Martin Luther King once said that our lives begin to end the day that we're silent about things that matter. People in healthcare are not silent, but we need to have the data to continue to have a voice for patients, for populations and communities. You must be the change you wish to see in the world. In order for us to lead change, we need to change ourselves, and to be able to approach patients, approach communities, approach populations with the information different way. That's how we can make changes, and that's how we can be effective. And the last one is one person can make a difference, and everyone should try. Each of you, I'm sure, are on your own life and professional journeys. And I hope and wish you well as you continue to evolve and develop. And I only hope that you will continue to work with me addressing the population health, and in doing so, hopefully helping create communities by promoting and protecting the health of all Virginians. So thank you so much. I think I'm going a little longer.
Thank you so much for that great talk. And now we're open for your questions and comments. John, would you take your microphone up there? Before we get started, let me tell all of you, we'll be coming up and bringing the microphone. Please don't speak till you have the microphone. Yes, we may be able to hear you in this room, but it's being recorded. These things show up on YouTube, by the way. So we really need you to use the microphone, and the microphone needs to be close to your mouth because it doesn't work when it's over here. Okay?
First,
And please say your name.
Ruth Bernheim from Public Health Sciences, and Dr. Romero, thank you so much for bringing this vision to UVA. I'm sitting with Dr. Lillian Peek and you from the Thomas Jefferson Health District, and I think we are a model here of how we have tried to collaborate, do the collaborations across systems, as you say, in the community. My question is about, I think for both of us, is about the future of public health. You lay out a wonderful vision for healthcare reform and a health system. What do you see as the future for health systems and public health systems working together? For instance, with ACOs, health navigators, community health workers, there's a new opportunity for us to think differently, but how do we do that? What do you see?
Absolutely, Ruth. Thank you so much, and good to see you and Dr. Peek. Nice to see you. She's one of my people. I love it. Thank you, Ruth, for that. Clearly, this is an opportunity for us to have public health and the healthcare reform actually start to partner together with the private sector and, in fact, all sectors. Some of the opportunities that we have is to actually look at the data and to actually look at where is the information being collected, how is it being analyzed, how is it being shared, and what are we really doing with it. And so we from the health department are very proud to say that we really are the holder of a lot of great information. We have vital records, we have health statistics, and many of you may or may not know, we actually have some of the oldest birth, death, and marriage records from the 1800s. I was actually there at Vital Records just last week, and I was looking at information from 1853. So talk about being able to analyze and have trends and assumptions, but to partner with the clinical world to be able to say, this is what's happening, here are our opportunities, how can we partner together to assure that activities clinically, prevention, treatment are really making a difference. So clearly the partnership is going to be there, and I think from a population health standpoint, partnering with our health departments, but certainly all those involved with the health of the public, we're going to need to have the data, and that's definitely one of our strengths.
Others? Just raise your hand. I'm glad to recognize you.
My name's Karen Knight, and I'm a medical education librarian here. And I just wanted to commend you. It was a wonderful presentation. I don't usually get excited about data, but seeing it graphically really spoke to me. And I use your website a lot to answer questions for other people. And I would just like to encourage you all to think about when you're designing your website to make it easy for people to find that data and the representations in the graphical forms, because I think those everyone can use to go and identify areas that we need to get involved in and speak to.
I appreciate that feedback and appreciate you using it. Please, everyone, you're welcome to our website. I must admit that it hasn't been as easy to navigate, and I know we have a couple of webmasters that are trying to work on making it a little bit more user-friendly. But exactly, and you know, we've learned and we're getting education about if you are 2 clicks away, you've missed the opportunity, or if information is not there within 2 seconds, you miss the opportunity. So I certainly take that information, but I would also offer to all of you, if you get a chance, you know, really explore our website, because we have an incredible amount of information. Again, lots of trends and all that, but hopefully you'll start to see an evolution in that website over the course of the next couple of years. Thank you for that, and thank you for using it.
Hi, my name's Emily. I'm a first-year medical student. You showed a pie chart with the costs associated to like differences in education and socioeconomic status, and I actually just didn't really understand where the cost differential, what that referred to.
Okay, and I apologize. I'm just trying really hard to go fast and to be able to offer opportunity, but let me walk through that particular slide a little bit more. Thank you for asking that, and congratulations for being here at UVA, and you have a great career ahead of you, just a lot of learning, so good luck. The pie chart is a summary of calculated economic impacts based on just those inequities and on 5 particular risks or conditions. So it was heart disease, it was cancer, it was strokes, and there were 2 others, and race and education. So what we were looking at was, based on just race alone, what was the economic impact? So when someone had to go to the emergency room, had to get prescriptions filled, had to go to a doctor's office, they had to miss work because they were sick, or they died and they didn't have income coming thereafter. That economic burden was translated, and they analyzed the data to say if someone was just of a racial difference, how was it attributed to that economic burden? If someone did not attain high school or higher, that translated it. So when we see the differences based on those particular 5 health conditions, we were able to mirror that to say, you know, someone who came in that just didn't have an income level greater than 10,000 really had this many more emergency room visits, lost days of work, died, and didn't have income. So it was trying to quantify it from dollars and cents, and to try to put the perspective. Does that help? Yeah. Okay. Yes,
Hi, I'm Kate Zenker. I'm a nurse. Actually, I just left UVA. I was an oncology nurse here for 15 years. I'm now doing hospice. Your appointment was kind of controversial, and you're well regarded for your data, which you've done a great job today, your people skills, your ability to bring people together. Do you feel professionally you've been able to kind of step into this and feel effective, or do you feel like you're sort of extremely exhausted from trying to keep the press away from your house?
Thank you so much for that. And first of all, let me say, it was an exciting thrill for me to have been appointed. And the story, I'm sure, has come out that I actually turned the governor down twice. And my husband is here. My husband Mark is here with me. So let me tell you, when my predecessor resigned, who was just fabulous, by the way. I've known her personally and professionally for many years. And she just transformed this role. And she really, really brought the public and private sector together like no one else had done previously as commissioner. So when she resigned over some of the abortion regulations, within 3 days, I got the first call from the governor's office. And I had 2 great jobs. I was in private practice as a family physician, and I was the chief medical officer of a community hospital in Chesapeake. And I had been, just president of the Medical Society of Virginia, so I thought, I'm kind of sitting pretty, this is great. But to have the governor call me and say, you know what, we'd love to have you come. Immediately my next phone call was to my husband, and I said, what do you think? And he was like, oh, this is just too much. And I thought, yeah, that's too much of a change. I respectfully said, thank you, but no thanks. Less than 2 weeks later, I got the second phone call. Had to think and pray about that a little bit more. But I still said, you know what, thank you, but no thank you. The third time, I just said, I was like, okay, sometimes, I'm a woman of faith, I'm Catholic, so I just said, you know what, I don't need to be beaten on the head, but maybe it is an opportunity. But I tell you, as a family physician, as chief medical officer, dealing with physicians, public health, readmissions, and then being in the role of president of the Medical Society of Virginia that represents 10,000 physicians, medical students, and residents across Virginia, and advocating for patients, I really thought, I was pretty much taking care of public health anyways. And I thought I knew public health, but coming into this role, I knew this much. But I tell you, having the experiences that I have had in each of my roles, and my mom was a family physician who I actually joined, and I practiced with her for 15 years. So I grew up with family medicine and medicine in general, so I kind of had that perspective. But I honestly say, with the tables I'm sitting at, with the conversations I'm having, with the people I'm meeting, I could not have been more effective, I think, because of everything. And honestly, and I know Dr. Pete can appreciate this, is sometimes I'll be at a table and there are these conversations happening between various stakeholders, and somehow ideas come to my head and I just say something and it's like, oh, great perspective. We didn't even think about that. And it's like, I guess I did know something. But honestly, I would say, just again, being a primary care physician, having a clinical background, seeing patients, administrative and policy-wise, I've felt extremely armed and ready. I don't think anyone could really be prepared to realize what this role really means, but I'll tell you, it has been the most, and my husband knows this because he lives with me all the time, and you know where I live. But I tell you, this has been the most exciting opportunity of my life. And I thought with all the things that I've done before, everything I've done, you can read my resume, but every step I just thought, oh my God, this is just great. But now every day, I wake up and I touch my pen and I just think, I am affecting the lives of 8.1 million people every day. My signature, my emails, my conversations, I could have an impact. So it's just really a great opportunity. And so, with my health district directors that have inspired me and educated me and really oriented me, they've been just a tremendous support. And there are some very committed, long-standing staff at the health department that have just made my life that much easier in terms of adapting. But it's a tremendous role. If you ever are curious about what the health commissioner does, it's outlined in the Code of Virginia, and next to the governor, there's really no other individual that has more authority that's prescriptive in the Code of Virginia than the health commissioner. So it's very humbling, exciting, confusing, and just every part is actually moving at once. But I tell you, just to be able to walk soundly as a physician advocate, as a patient advocate, and now as a population health advocate, it just makes it that much more fun to meet people and hopefully let them drink my Kool-Aid.
Thank you. I'm actually, can I take 1 second and come to you next, because I want to take the privilege of holding the mic in my hand and ask you what amounts to sort of a follow-up question to that lovely testimonial. Thank you for that. And that is, this was a great presentation of data, I agree, very gripping. It's not necessarily news. We've known about disparities for a while. They haven't changed much, unfortunately. We've known for a while that we really need stronger primary care networks. It was one of the things that 20 years ago started the Generalist initiative that spawned the Generalist Scholars Program. I guess what I'd like to hear from you is, what do you think is different now, if there's anything, about the will to make a difference, and, of course, going along with the will, the funding?
Absolutely. I think Ruth Bernheim set that up, and it's called the Affordable Care Act. Talk about a mandate to actually have these conversations. And that's where, again, our information and our data are now the opportunity to have discussions. okay? And that's where, as I've tried to talk to just physicians and nurses and people who are really trying to make a difference because your heart is in the right place, we need to have the data and we need to have the ability to measure. But you're right, we haven't changed much because the political will, the focus, the primary care, the workforce hasn't really been focused on primary care. And that's one of the challenges of the United States in general, in that we really promote some of our students to actually see that, primary care is not the most glamorous. They work the hardest, they're really, the workhorses of the industry. But in fact, if you look at who the patients are really looking for, they are looking for someone who can hold their hand and talk to them as a person and to work with them. And that's why having teams really is going to make a difference. And I think as we are having conversations where now legislators are learning so much about healthcare delivery, about healthcare payment, who should be giving them that education? It really should be the medical field, providing the clinical expertise and in fact the process improvement expertise. It should be the health plans to provide us some insight about cost containment and perhaps cost management, but it should be the patients to be able to tell us what we're doing wrong. And I tell you, if you can have whatever political leanings that you want to about the Affordable Care Act, but in reality, it's brought healthcare to a discussion that we've had before, but it was shot down. But now, by nature of need, and by really focusing on the data, and be able to say, you know what, this is just the right thing to do is to address these disparities and to address our communities, and hopefully getting the right leaders in the right seats to help drive that. And it's not easy being a leader. Many of you, to be able to get to where you are today, you had to be a leader. And it gets lonely to be a leader because oftentimes you have to kind of push through old cultures and push through old ways of thinking. But when you've got the data and you've got the motivation, you've got the drive to say, you know what, we've got to do better. We're the United States, one of the wealthiest nations in the world. And why can't we improve our birth weight for children? Why can't we have more of our children, attaining high school degrees? Or diplomas? I think the will, the way, the funding is going to be tricky, but I think, again, since government is starting to pay for it, it's a pretty complicated system, but I think the time has come.
I'm Lois Shepard from the Center for Biomedical Ethics and Humanities, and mine's kind of a related question, but maybe I'm going to try to pin you down just a little bit more.
Sure.
Which is, I'm wondering if you could speak about the issue of the relationship of politics and public health. So, public health, seems to be about the long view, the broad view,
Yes.
data-driven. But in fact, the views of elected officials do have an impact, not just with funding, but for example, those abortion regulations, which the Department of Health got into a scuffle about, and with the Affordable Care Act. We're in a state that has not embraced the Affordable Care Act. So how independent is the Department of Public Health, the Department of Health? How independent can it be? How independent should it be?
Exactly.
I think we can't just act like there are no obstacles here.
Exactly. Exactly.
And it can't just depend on personalities. So anyway, can you talk about
Absolutely.
how we should do this in the future and what we need?
Absolutely, and thank you for opening that can of worms. In reality, you're so right. If you look back 2 years ago, the Virginia Department of Health was just a great workhorse. It collected the data, it prevented spread of illnesses, it inspected restaurants and hotels. It was happy to do the things that it needed to do, and only made the news when we didn't do things right. Now, because healthcare has gotten so complicated, there are conditions like abortions, but we're never going to win that argument because you're going to have people on both sides. Advanced directives, again, sensitive issue because we love our seniors, but they are paying, or their expenses are really significant when it comes to Medicare dollars. So the question is, are we political? Okay, we're not intended to be political, and I will tell you, as I lead my staff of 3,800 people, we're trying so hard not to be political, but rather to be the neutral public health officials and to relay the data and to go by the information. What is a challenge, and you're so right, in that our legislators, our policymakers, are people who are usually wonderful people, very bright, very specialty driven by their own backgrounds, but oftentimes need education. And healthcare is usually not one of their fortes unless they're physicians. Plus, they're usually really focused on the next election. So talk about attention span, and talk about everyone from education, public health, public policy, public transportation. I mean, they're all trying to get the legislators' attention. And when you're talking about ADD, talk to a legislator, talk to a legislative aide, because bless their hearts, they've got 1,000,001 of their constituents that are trying to talk to them. So that's the political realities, and we recognize that. We recognize that, though, and we have to deal with it. That's a reality. Virginia is one of the only states, if not the only state, that has a one-term governor, 4 years. So talk about focus, plan, do it. And again, having a personal agenda. We kind of have to go with what we're told, but fortunately, there's a check and balance where the governor and his executive staff really can only abide by the will of the General Assembly, and the General Assembly obviously abides by the will, hopefully, of the people. So what we're hoping, as I'm continuing to partner with my staff, and particularly my district directors, is to be able to say, recognize the political game, try very hard not to side one way or the other, but side with the patients and the communities and the populations you're trying to serve, and just try to manage those relationships, because when it comes to making policy changes, particularly at the local level, city council members, municipal leagues and all that, it's truly relationships, and oftentimes we're finding it's education. And again, repetition of education and all that, from our standpoint, it may seem, oh my God, I'm giving a conversation or having this conversation for the 1,000th time. But you know what, for the person that you're having a conversation with, you could be the first. And again, having that elevator speech, having a couple of 2 or 3 bullet points, just to feed them information and to have them develop a relationship to say, you know what, public health, we're here to serve you. We are here as a trusted source of information so that you can make a difference for your constituents. You could be a public health advocate. You can really help make great policies that will live and have a legacy that will outlast you. Talk about playing politics, but having your agenda really not be selfish, but rather be the public health. So a lot of it is truly education and meeting people where they are, particularly legislators. And one thing, if I may just put a plug in, Ruth and I are part of, very briefly, a program called the Excellence in Public Health Law program. And it's a program that's funded, it's only $10,000, so it's not huge funding, so it's more just the exercise, with the Robert Wood Johnson Foundation and the Aspen Institute, which is a very forward-thinking think tank in Washington, D.C. And our goal is actually to work together to develop a model process for developing public health law and policy. And what we're recognizing, again, Robert Wood Johnson and Aspen pretty much defined who they wanted on this team and who they wanted to work together with. And so the state health officer, and there are 8 states who were selected, the state health officer is the team leader. We have a governor's level policymaker, that's Secretary Hazel on our team, so we got a great team there. And then we have 2 other leaders from the Department of Health. We have a senator, Senator Emmett Hanger. We have a delegate, Delegate Scott Garrett. We have Ruth Bernheim, expert in public health science and ethics. We have Sarah Stanton from our legislative services, Robin Kurz from our Office of Attorney General. And if you think about that, you would think these people talk all the time, but that is not the case. And when you think of, again, Virginia has a very unique situation in that we have a General Assembly that's only 45 to 60 days long. When ideas or concepts, advocates, constituents come up to a legislator and say, we want to have this law pushed through. Legislator, again, wants to look at his next election. They want to go ahead and get elected. So sure, we'll write the law. And so policies and law try to move forward very quickly. And oftentimes, the biggest stakeholders may not be engaged, or the process may not allow the vetting of a particular initiative as well as it should. So we're hoping that through our exercise, having conversations between all these different sectors of decision-making, policy-making, and state agencies, that we'll in fact have a process to be able to say for public health, knowing that we want to have the most effective law and policies, we want to have this process. And so if anyone has an idea, first of all, we want to say, are we already doing it? Do we already have a law or policy in Virginia that addresses that? And if we have it, great, that just means we need to educate and promote that message. If we don't, let's look at locales that might be doing it across the nation, or let's look at other states and see what we can do and basically not reinvent the wheel. So I think we're pretty excited that this is only kind of a year's project, but I think the result is not going to be how we spend the $10,000. It's not going to be really the outcome of just this particular project. What I think is going to be most helpful is building of relationships between all these different team members and then the rest of their staff, and to be able to continue to have that conversation so that everyone is hopefully getting on the same page.
Who's next?
John.
I'm determined to stick to the smile, so now you have to wait for John.
Thank you guys for coming. I was wondering how, a lot of people are insured by the government, but even more are insured privately. And how can the state health commission, which is all about public health, right? How can they help get the private side on board with addressing these health disparities? Because so often we think of the government's responsible for that, but how can we get everybody on board?
Absolutely. Thank you for that question. And many of you may not realize that there are about 400,000 Virginians that are not insured at this moment in time. And Virginia is not one of the states that chose to expand Medicaid for various reasons. But we're probably the only state that's really doing the most thorough evaluation of expanding Medicaid and whether we should, and only if certain changes to the current Medicaid program are made. So with that conversation alone, being able to say, what does Medicaid cover? What does it take to qualify for Medicaid? And what really should be the outcomes? How should we cover particular patients, and what kind of education should we have? But I'll tell you, you're right, for the private payers and also some of the private companies, this type of information is starting to penetrate into their discussions, because when you have employees, let's say of a company, you have employees that are going to the emergency room or that are not getting their diabetes diagnosed and they're missing days and all that, they're recognizing, oh my gosh, that's a higher expense. How do we address this? So again, getting good primary care, getting the appropriate information to them to clarify that. When it comes to the uninsured, especially the hospitals, they're recognizing that those patients that are coming to the hospital once, twice, frequently, because of not being able to get their medication, not following a low-salt diet, not being able to get in to see a primary care provider, the private insurers are starting to wonder, wait a minute, if people are starting to go to the emergency room and they're affecting the premium of my patient, or my group and my people, the insured people that I'm already trying to cover, oh my gosh, I need to start looking at why is the cost factor continuing to go up. So it's really providing them the information and letting them realize that many of that 400,000 people who may qualify for Medicaid or even be eligible for the health insurance marketplace that's going to be starting here shortly, many of them may still choose not to get health care because they're going to be choosing between, do I pay for my mortgage or do I pay for my health premiums? Okay, and recognizing that, again, if my employee doesn't get insurance, they're going to end up sick, they're not going to be productive, they're not going to be able to do that. So trying to engage them in that whole bigger conversation of how do you keep your expenses down if you're an insurance company? How do you keep your workers at work if you're a business? And how do you keep your employees well? And again, having that great information of, some of the information I didn't get to share with you was looking ahead, what is the chronic disease burden of heart disease, heart attacks, strokes, tobacco-related illnesses, obesity, okay? And once you throw that data up there and say, your employees, if you want, we can help you measure what percentage of your workforce are obese, are at risk for diabetes, are at risk for heart attacks. And again, we're actually seeing there's some people who are starting to shift. We have two initiatives that are underway that the Department of Health is leading with the health plan for the hospital systems. One is the all-payer claims database, which is actually looking at the claims that are paid by the insurance company and hoping that that information will be aggregated so that we can have public health information to be able to look at population management. And that'll be feeding into the ACOs and hopefully physician practices so they can get a feel for what they need to do differently. And we're also in the process of setting up the health information exchange, where again, information hopefully can translate from one institution to another regardless of the electronic medical record, and have patient information shared to have the best outcome for patients when they visit various entities. So, great question.
Thank you so much. I'm afraid our time is up, but we owe you a great debt of gratitude.